real-world people co-infected with HIV hepatitis C.
Well, thank you. Good afternoon, everyone. And let's just begin. My talk is going to be very different from everyone else's talk today. So the development of direct-acting antivirals has been rightfully described as revolutionary. In less than 3 years, Cimeprevir, Sofosbuvir, Ledipasvir, the AbbVie 3D drug have all been approved by licensing authorities around the world, with many other drugs in the pipeline. From what we've seen today and from what has already been published in clinical trials, these drugs are well tolerated, more conveniently dosed, and highly efficacious. With as little as 12 to 24 weeks of treatment, sustained virologic response rates range between 57 and 94%. And this is across genotypes and fibrosis stages, and it's a significant improvement from previous generations of therapies. However, it's unclear how effective these drugs will be in difficult-to-treat populations, such as those co-infected with HIV and hepatitis C. Bridging this gap between efficacy and effectiveness will require a focus on the generalizability of clinical trials. So in the real world, substance abuse, comorbidities, psychiatric conditions, advanced liver disease, and drug-drug interactions with existing HIV therapies are all common and among the primary factors that influence both access to treatment and outcomes. Trials evaluating these new agents have so far included relatively small numbers of participants. If you look at the subgroups, they're between 6 and 114 people with very strict eligibility criteria, therefore likely excluding a substantial proportion of co-infected individuals. So the question we asked was, if a significant proportion of co-infected people are excluded from participating in these clinical trials, then how generalizable can the DAA trials be for people in the real world? So what we did was perform a review of all phase 3 trials evaluating second-generation DAAs within a co-infected population. We identified a number of drugs, and then we narrowed our search to the trials that were published and trial protocols were also available. This left us with 3 drugs: Cimeprevir, published in 2014, the Photon-1 study evaluating Sofosbuvir, published in 2014, and the Turquoise-1 study evaluating the 3D combination that was recently published in JAMA and which we got a presentation on today as well. And for those who've never recruited patients into a pharmaceutical-sponsored study, inclusion-exclusion criteria is not as straightforward as what is briefly reported in publications or on trial registries such as this one. Protocols consist upon pages of very strict eligibility criteria that need to be followed. We then use the Canadian Co-Infection Cohort as a representative population to evaluate the percentage of current cohort participants that would be eligible to be screened in these trials based on trial protocol eligibility criteria. So as Laurence has already presented, the CCC consists of 18 centers across Canada. Participating centers include large urban tertiary hospitals, community-based hospitals, private clinics, and street outreach programs, and this is all to attempt to capture a representative population in care. So as of January of this year, 1,423 participants made up the cohort. We excluded anyone who did not have chronic HCV infections, those who had died, lost to follow-up, or had withdrawn from the study, leaving us with 615 participants who would have been eligible to receive HCV therapy. And then we further subdivided the patients into either being genotypes 1 or those being genotypes 1, 2, or 3, and this was to reflect the trial populations that we were analyzing. So just some demographics of the CCC at their last visit. Independent on how you slice the cohort by genotype, a quarter of the cohort is female, 20% are of people of Aboriginal descent, poverty and history of injection drug use is very high, and 30% of the cohort is actively engaging in injection drug use. Time since HIV diagnosis is approximately 16 years. 87% of the cohort is on antiretroviral therapy. We have equal percentages of those who are on tenofovir-based and abacavir-based backbones, and only 22% of the patients are on raltegravir. The majority of the cohort has an undetectable viral load and relatively high CD4 counts, and the duration of HCV treatment is approximately 22 years, making this cohort at high risk of advanced liver disease. So what we found: the most exclusive eligibility criteria across all trials was restriction to specific antiretroviral therapy, excluding 63 to 73% of the cohort. Active drug use, and this is excluding marijuana use, resulted in 54% of the cohort being excluded. Overall, as many as 1 in 6 participants would have been excluded for either having a detectable HIV viral load or not meeting the CD4 requirements. Although excluding participants due to safety reasons is legitimate, specifically clinical cutoffs for anemia, renal, and liver function, these criteria resulted in relatively few exclusions. So overall, only 5.8% of the cohort would have been eligible to participate in the Semeprovir trial. Even if antiretroviral eligibility was not considered, so this would be assuming that we could switch these people to comparable regimens, still, 77% of the cohort would not be eligible to participate. Similarly, only 9% of the cohort would have been eligible to be screened in the Sofosbuvir trial. Again, ignoring ARV restrictions, this still would have led to 75% of the cohort excluded. And despite the enhanced ease and tolerability of an all-oral, interferon-free regimen, eligibility into the 3D trial was just as exclusive as the ones with pegylated interferon and ribavirin. Only 6.6% of the cohort would have been eligible to be screened in the 3D trial. So, trial results are used to support licensures, inform health authorities in conducting cost-effective analysis, and guiding clinical decision-making. But to make these inferences to a wider population, trials need to be externally valid. In the trials themselves, screen failure rates due to eligibility criteria ranged between 29 and 44%, and these were all in highly experienced sites. Fundamentally, trial participants are different. They include highly motivated people who receive compensation and extensive support from trial staff, including for adherence. Already, based on real-world data, we have signs that efficacy rates are going to be 5 to 15% lower than what has been published in clinical trial reports. Now we have illustrated that the vast majority of co-infected patients would have never been included in these clinical trials, although these are all individuals who are able to access care and maintain HIV antiretrovirals successfully. Unless mandated to do so, the pharmaceutical industry really has no incentive to evaluate DAAs in a representative population, and that's where observational study designs that estimate an unbiased treatment effect will be necessary to determine how effective these therapies will be for real patients. Until then, caution should be used when translating these results into the real world. So I'd just like to acknowledge the participants of the Canadian Co-Infection Cohort, some of whom have been participating for more than 10 years now, my supervisors, the co-investigators, and their research staff, the funding agencies that support the cohort, and the funding agencies that support me as a student. Thank you.
So thank you very much for that fantastic talk. Do we have any questions from the audience? So, I'll get us rolling then. So there are some mono-infection cohorts that suggest that the SVR rates are reduced in real-world populations and others that don't. So I guess my question to you is, what do you anticipate we're going to see in the co-infection world? And what can we do to try and maximize the likelihood of hitting the same outcomes that we see in these clinical trials?
I mean, I think if you're looking for the same outcomes, then you have to create settings that reflect trial settings. So that means a lot of individualized patient engagement and so that patients could get the maximum results. The reasons that you have different protocol or different responses from real world data is it depends on where they live and what their standard of care is. So that's the reason why you get different results. Mm-hmm.
Have you thought of using this data to potentially sort of model what the, I mean, your 5 to 15%, I assume, is a sort of ballpark figure of what you would anticipate the difference to be in the real world, but to actually more systematically project the data into modeling?
I personally don't like modeling at all, so I'm not going to be doing that. But we are prospectively collecting all of this data, and we'll be looking at this using different causal methods.
Question from number 4?
Bowling, Los Angeles. You know, I think the implications of this are quite profound, and I think we've got to be kind of careful about, you know, how you proceed with the next recommendations, because insurers and people who pay for these drugs use the licensing indications to decide what they're going to pay for. Mm-hmm. And as you've shown, eliminating so many people who are really appropriate for therapy from the licensure indications, you know, sets the stage for ongoing, perpetual difficulties in getting all the people who are really appropriate for therapy into therapy. So we've got to be careful about, you know, I would encourage you to, you know, continue to come up with the next suggestion as to how we should proceed from this.
Well, hopefully we'll be collecting this data, and in the next couple of years we'll be able to present again.
I think about 1 minute, but I think we can move on if there's
Sure.
So I think it's interesting data, and maybe did you consider, since you have a co-infected population, did you go back and look at the HIV trials and whether these patients would have been included in their HIV trials to see if, you know, because you said they're highly suppressed on their HIV regimens, maybe you could actually make an argument to that point that despite maybe not being included in HIV trials, they've done well on HIV therapy, and you could extrapolate to HCV.
Okay, very good suggestion. Thank you.